Okay, so it's 11:03 on the East Coast at least. I'm going to begin our lecture today. This is a national AMSSM online lecture, part of the series that we have put together for fellows, sponsored both by the Education and Fellowship Committees. This is meant to serve as an adjunct to your individual programs, educational programming, and not necessarily meant to be taking over from that. We are trying to give fellows access to national speakers, guest speakers who have been very kind to volunteer their time. We're hoping that some of the information today will help with your CAQ, but we also expect it to help with your clinical management of patients during your fellowship. Just as a reminder, there is a subcommittee who have been working hard on this. You can see the names there. And we have recently met to talk about our second quarter topics, which will be publicized soon. So my job today to start with is to introduce our guest speaker for today. And Professor Herring is going to be talking to us about concussion. He is the Zachary Lystedt Sports Concussion Endowed Chair at the University of Washington and is a clinical professor in the Department of Rehabilitation Medicine, Neurological Surgery and Orthopedics and Sports Medicine, and is the medical director at the University of Washington's Sports Medicine, Spine and Orthopedic Health Center. He's also the co-medical director of the Sports Concussion Program. So Dr. Herring is someone I've heard many times over the last 10 years talking about concussion, and in particular through his advocacy efforts at a state level in Washington State to advocate for students and student athletes who have had concussions. And it was his leadership really that helped to have all of the states across the country, starting with the Washington State, to have laws that prevent coaches and others from allowing people to return to sport on the same day that they may have sustained a concussion. That's certainly been very important legislature that we've all benefited from in terms of improving health outcomes and concussion outcomes in particular. So I will be in the background helping moderate the session. I am now going to hand over to Dr. Herring. I do want you to all make sure you've got your devices on mute, and please do submit questions through the chat function, which I will then be trying to have some time at the end for us to navigate through. If we do have time, I have some CAQ questions at the end, but that remains to be seen how many questions there are. So without further ado, Dr. Herring, please join in.
All righty. Good morning, everyone. And Hamish, thank you very much for the opportunity to speak here, and also really an honor to speak in front of you. Certainly a concussion expert in your own right, and thank you for all the work that you've done. And welcome everyone to the new reality of how we teach, and look forward to sharing some information with you, and then hope we have some time for questions. My title, I would like to point out that my title uses an active form of this adjective, persist, and it does say persisting. And I would like you to focus on that a bit as we go through the materials today, and then I can maybe explain why. My disclosures, I'm going to talk quite a bit about the Concussion and Sport Group's work. That's the group that publishes the paper every 4 years. I've been fortunate to be a member, so I would be mentioning that with some regularity. Here's some other relationships I have. I don't plan on directly speaking to them, but I have a variety of different research positions, advocacy positions that have shaped my thinking. And so we will talk a bit about Berlin. Right now, actually, next couple of weeks, it should have been in Paris for the next concussion consensus meeting, but that's been pushed back for a year. But there is a plan to update the 5th International Consensus Conference now in 2021. As you start your fellowships, I suspect you all are already aware of things about concussion, but let's just do a little bit of background work and then kind of cut into talking about some of the ones with persisting symptoms. It's an extraordinarily common problem. Around the world, the United States is no different. This is a really common problem, sports-related concussions. You know, most of them are not even seen. At least half of them are not ever even really evaluated. So that's the case internationally. And the ones that are evaluated are mostly seen as outpatients. So this is an outpatient ambulatory injury that rarely is seen in the emergency room and even less rarely hospitalized, but always important, of course, to make sure you don't look for more serious brain injury. There's been certainly a rise in the rate of concussion and the lifestyle law work and the other state laws work that Dr. Kerr talked about certainly may explain this in terms of reporting bias. The awareness has increased reporting. So the question, and a phrase often used, is this crisis, is there a concussion crisis? There is a crisis, and there certainly is a very dangerous thing that you can do to young people that will affect their long-term physical, psychological, and neurological health. Without question, make them perform less well academically and have psychological consequences of lifelong issues. And that crisis is actually the one of physical inactivity. So brain injury is not new, and it is important, but perhaps the single most dangerous thing we can do to affect the long-term neurological health of young people is to have them be physically inactive. So the challenge for us is to keep kids active and keep them safe. Concussions have been talked about for a long time. Races, the remarkable Persian physician, the father of pediatrics, the first person to describe measles 1,000 years ago, wrote an extraordinary treatise on concussion. And his work has been followed by many others. So this is not a new problem. It's been described well in the medical literature literally for centuries. So I'll challenge you by saying, so if concussion is not new, what is new around this topic? And I will try to build a case for what may have been changed in the way that concussions are managed and recognized. The Berlin conference, and any of you who've read any papers know that this definition of concussion is probably the most widely used definition in the world, and it's this sort of traumatic brain injury which is induced by force, and it's a direct blow to the head or an indirect blow, and this should be very common knowledge to all of us. And usually it's a rapid onset of short-lived impairment that resolves spontaneously. Some, however, linger, and some develop more slowly. Certainly, in terms with using advanced imaging, there's no pathological changes, but on normal MRI, very rarely. The acute clinical symptoms really are more functional disturbance than the long-standing structural injury that we can see with routine imaging. And the symptoms are broad. Probably depends upon what part of the brain is affected, and loss of consciousness, as you know, in sports-related concussion is rare, less than 10% of the cases. Usually the clinical course follows a kind of a typical sequential fashion. However, in some cases, the symptoms may be prolonged. That's where we were before the Berlin consensus meeting. And we added a sentence to the definition, or paragraph. And that paragraph, here in italics for you, is that the clinical signs and symptoms cannot be explained by something else. So the key here is that be careful about symptoms that are persisting after a concussion to make sure that they're not due to some coexisting, pre-existing, or resulting issue. And I think that has been an important move forward in the discussion of sports concussion. So, recovery after sports concussion. The one thing that changed in Berlin, we used to talk about 7 to 10 days. It's pretty clear, particularly for youth, that this is really up to 4 weeks. I think that's important for you as providers and practitioners. You don't want to give a family a timeline, which is really not true, and then they become anxious if their daughter or son is not there in that timeline. Now, neurobiological recovery may take longer, and that's of interest in the research piece, and all the advanced imaging and biomarkers and electrophysiologic studies and genomics are quite interesting, but they are not yet clinical tools. The one thing that we do know is that there's a growing body of literature that psychological factors play a significant role in symptom recovery and contribute to persistence of symptoms. Not to discount the brain injury, never discount the brain injury, but it's what the athlete brings to the injury often has a big influence on how long the concussion lasts. So the strongest and most consistent predictor of who gets better is the burden, the symptom burden. How many, how severe, and how acute. That's why the initial sideline assessment is so critical, is to get a sense of the burden of the injury. Conversely, low-level symptoms usually prognosticate favorable recovery. But if problems develop, for example, exacerbation of a migraine headache disorder or development of a post-traumatic migraine disorder or mood changes, they can certainly result in symptoms being persisting. I'm hoping in Paris we can change the word persistent to persisting, as I'll explain to you. And adolescents, children, and young adults with a pre-injury history of mental health problems or migraine don't do as well. We know that. Once again, all about what the athlete brings to the concussion. People talk a lot about kids with ADHD recovering more slowly. I don't know that that's true. They recover differently. And it may be a bit of a challenge, but just pegging them as absolutely going to have a longer recovery may not be accurate, but they do require special attention. There's been really very little research on recovery in kids under the age of 13. However, the teenage years, particularly high school, might be the most vulnerable time period for persisting symptoms, and that risk appears to be greater in girls and boys. That may be due to girls being more robust in reporting. The cornerstone of brain injury, mild traumatic brain injury, was physical rest. That was preached to us because activity can exacerbate symptoms and it can prolong symptom duration. I do think it's important to tell your patients that if a concussed person is too active and their symptoms get worse, they haven't damaged their brain further. They just may retard their recovery. Physical rest, yes, and there's this whole idea of cognitive rest. You know, not just schoolwork, but other things, texting and video games. This idea of hopefully relative cognitive rest has moved to the forefront. For this long time, this idea of cocooning athlete, oh my goodness, you've had a concussion, go to your room, stay in a dark room, don't look at anything, don't read anything. We've moved beyond that. And I think it's important, hopefully this group knows that this idea of absolute cognitive rest really does not have a role for mild traumatic brain injury. And indeed in Berlin, the idea being that the idea for rest was that it would sort of mitigating post-concussive symptoms and promote recovery, but realistically, there's really not a lot of evidence that completed rest beyond 24 to 48 hours is helpful. As a matter of fact, it's probably not helpful. So the move to earlier activation is a trend now in the management of concussion. Once again, not activation that produces symptoms and not activation that involves physical contact, but no prolonged physical rest and no absolute cognitive rest unless absolutely necessary. So these are not just athletes we're talking about, they're student athletes. And another thing which is important is they have a job and their job is to go to school. So we want them to not completely return to sport until they return to school. And that means schoolwork with the same amount of effort that they're doing all their other social activities. So they need to be well cognitively, actually need to be well emotionally as well too, before they're released for full physical activity. Let's talk about the ones that don't do well, and this will populate your clinic soon enough. So outside of sports medicine, for those of us who kind of have wandered around in the brain injury world for the last few decades, we know that there are predictors for who will not do well with non-sports related concussion. There's a lot of literature, and that literature often points out that those with pre-existing psychological issues and mental status issues, those with family and family factors, that's sort of a dysfunctional family, and certainly with those with previous head injury, but also learning difficulties or behavioral problems, may have increased risk for long recovery, way outside the sports medicine literature. So not surprisingly, you would think that athletes may have the same struggles. And this retrospective work, which is, I think, helpful in this space, looking at this case control study of 40 patients, it uses the word post-concussion syndrome, which I think is an inaccurate statement of what that actually is, but the point being persisting symptoms for more than 3 months. And there's a lot of data collection on these athletes prospectively. They knew who they were, they knew about key medical, psychiatric, and family history. They looked at symptom burden, and they looked at recovery. And so who was at risk for developing persistent symptoms after concussion or persistent symptoms? Those with the history of concussion, we know that if you've been concussed certainly more than once, you may seem to recover more slowly statistically. And those who continue to participate and then had delayed symptom onset, we know that also playing with an acute concussion can delay recovery. As far as other factors, mood disorder, life stressors, family history of mood disorders, and even family history of migraine, those predicted slower recovery. What did not predict slower recovery was pretty much everything else. So once again, maybe it's what the athlete brings to the concussion in terms of his or her life experiences, family dynamics, and mental health. It begs you to ask those questions of your athlete when you see them. This is nice work as well too. This is a longitudinal study of sports-related concussion with a large number of athletes, both high school and college, looked at and followed for 3 seasons. A very thorough preseason baseline assessment, and then an hour post-assessment at these timelines, including up to 45 days post-injury. This is what the baseline assessment included. And for purposes of time, we'll just leave this up here and let you digest it later, but it does include this brief 18 index, which we'll talk about a little bit. And so the statistical modeling, I think, was very solid. And of these athletes, 127 were concussed and followed serially up to 45 days. All right. So what did we learn? We learned that, once again, those with the biggest symptom burden that was the best predictor of recovery. In terms of duration, their pre-injury somatic symptom score, this brief 18, was the strongest pre-morbid predictor of symptom duration. So making the case here, it's all about who the athlete is. So then let's put this in context. So how do we treat persisting symptoms? Well, exercise. John Leddy's revolutionary work. John was very courageous and thought, I'm not sure about this cocooning business. Maybe we should exercise people with persisting symptoms. We do it for moderate to severe brain injury all the time. So what did he do? In his initial work, he looked at a small group, wide age range, with persisting symptoms after concussion, and he graded them. And then he exercised them. And he exercised them until they got symptoms. And what did he learn? So he pushed them. He said, okay, this is how much you can exercise. This is when you get symptoms. We'll back that down a little bit, and we'll exercise you at that sub-maximal exercise rate, and we'll keep changing it as you get better. Did that work for those patients with months and months of symptoms? Well, yes, it did. Their exercise time improved, and their symptoms got better. There was a fairly broad range here, but he was able to demonstrate, and this was really a safety study by Dr. Leddy, that exercise was safe, and actually the patients did improve, even those with long-standing symptoms. Of interest, their cardiovascular fitness parameters really didn't change. So there was really no change in resting heart rate or blood pressure. And he plotted heart rate versus projected VO2 max and systolic blood pressure versus VO2 max. You know what? They didn't change, but the patients got better. And then John Leddy recently looked at a multi-center prospective randomized clinical trial of young athletes. And then he started exercising them within 10 days of their concussion. Once again, pushing the idea that we maybe should exercise a bit early. Did the same thing. He did the subsymptom threshold aerobic test, and then he had an active placebo group. Actually, he did a stretching program. He was very careful that they got the same amount of exercise, they got the same amount of attention, And they measured outcome measures in terms of days from injury to recovery. Recovery was not return to play, it was just being asymptomatic. And that recovery was confirmed through assessment by a physician who was not part of the treatment group. This is a very well done study. He started treatment for both groups about 5 days post-injury, which is certainly sooner than we often exercise them. And then they had, both groups had baseline tests, weekly treadmill tests, and based in the same attention. And they adjusted the regimens weekly. And there was a fairly big exclusion criteria to make this study pure. And a lot of excluded athletes here were those with ADHD, learning disorder, depression, anxiety, or history of multiple concussions. So those who exercised got better than those who didn't. You know, they saved about 4 days off their recovery term. Now remember, recovery was defined as being asymptomatic. And by research design, we don't know if this works for these athletes who are at higher risk. The very ones I've told you may take longer to recover. And Dr. Letty's purpose was not to measure fitness objectively. So we don't know what exercise dose and for what person. So we know that exercising people gets them better. We just don't know what, if there's a dose or an amount or a frequency of the exercise that may do so. Catherine Snyder is a renowned physiotherapist in Canada and has taken a leadership role in the International Concussion Group. And she did some very interesting work looking at a prospective randomized controlled trial of concussed patients with symptoms of dizziness and neck pain for equal to or greater than 10 days. Small group, 15 in treatment group, 14 in control group. And for up to 2 months, she exercised both groups. One got usual therapy, but for the other group, she added focused therapy for cervical and vestibular rehabilitation. And her primary outcome measure was, when did they get back to sport? A lot of secondary outcome measures. The study was not really powered for these measures, but I found them to be important for the conversation. The one thing was not done was formal vestibular function testing. What did she find out? In terms of primary outcome, those who she put in vestibular therapy, 73% were back to sport within 8 weeks versus a control group of 7%. A very compelling conversation that perhaps vestibular and cervical spine therapy in a selected group would be tremendously powerful. In terms of those secondary outcomes, which one of those changed? Well, the SCAT2 changed, and the dizziness handicap inventory score. And I don't expect anybody to know what that is, but that's a patient-reported score that has 3 components. It has a physical component, it has a functional component, and it has an emotional component. So though the evidence-based or validated outcome tools, part of the SCAT was validated, certainly the symptom checklist, but there was less robust improvement in these secondary outcome measures, but remarkable improvement in clinical outcome. This is a group with, I need to disclose, I was involved as a collaborator in this study. So what did Dr. McCarty do here at Children's Hospital? She took a prospective randomized controlled trial of patients with persistent symptoms of equal to or greater than a month following a sports-related concussion, and she randomized them. She did not do a submaximal exercise assessment. She didn't do a vestibular screen. She just said, okay, we're going to randomize you. Half of you are going to get collaborative care, and half of you are going to get your usual care. And collaborative care means cognitive behavioral therapy, evidence-based psychopharmacology, and a care coordinator. So they were randomized, those 2 groups. They were assessed up to 6 months, and she used primary outcome measures, all of which are validated outcome tools. And secondary outcome measures, once again, these are all validated outcome tools. So what did she learn? Outcome at 6 months. Those who had the collaborative care were much better in terms of symptoms. Their function, both by the patient report and parent report, was remarkably better than those who did not have the collaborative care. Remember, that's cognitive behavioral therapy. Psychopharmacology is indicated in someone to navigate them through care. Their depression had also improved significantly as compared to controls. And perhaps for those of you who have been in a concussion practice, maybe the most important thing was that they were satisfied with their care as with their parents, much more than the group who did not have the cognitive behavioral therapy. So this is kind of an interesting, dilemma here. There we go. So Dr. Letty exercises his patients. He doesn't do vestibular therapy or mental health work. Dr. Snyder does vestibular therapy, no exercise and no mental health, and Dr. McCarty does mental health only. And everybody got a trophy. Everybody got better. And this raises interesting questions of what are we treating? So are we treating the brain injury, or are we treating the mind of the brain injured patient? And I do want to dwell on this for a minute because it's really, there's a lot to learn from these interventions. These are all very good studies by leaders in the concussion field, and they show valid outcome, but you attack what looks like the same problem in 3 distinctly different ways. So I think, you know, I like this slide. Yes, the number of pirates has increased in the last several years, and yes, the global temperature has risen. So is that a causation issue? Did the rise in global temperature result in more pirates? Probably not. So this is the issue of association versus causation. So I'm going to say that I'm a doctor, I'm a physiatrist, and I'm trained in brain injury, and I take brain injury very seriously. And I think you have to take the brain injury of each of your patients very seriously. But I also think we have to be careful about the association of causation with the event without understanding what other factors may be present. So this, I was one of the authors of this AMSSM paper, and I was amazed at the work that was done there. And this graph, this visual was come up with by the group, because I know there was this idea of saying, well, this is a vestibular concussion, and this is a cognitive concussion, and this is a mood concussion. And that type of linear thinking is very appealing to healthcare providers. We like to categorize things. But if you look at the extraordinary amount of overlap of all these, what lives in the middle of all this? You know, I feel like I'm in a fog. I can't remember. Yeah, that could be cognitive, but it could also be emotional. I have sensitivity to light. That could be ocular, but also people who are depressed say the same thing. I have irritability. I have sadness. You know, you can be sad also because you have a headache disorder. So there's so much overlap, and we need so much more work about really understanding what a mild traumatic brain injury truly is. But I think we need to be very careful about this idea of subtyping mild traumatic brain injury. Certainly you need to do a thorough assessment, but pigeonholing patients at this point, I think, may misunderstand or misrepresent who they are all the time and what they bring to the concussion. And that's why I like the word persisting, not persistent, because persisting symptoms does not imply that the symptoms necessarily are all due to an event. It's an active form of the noun, of the adjective. It also suggests that since it's persisting, it's not necessarily permanent. So when you intervene to a patient, it's important to understand who they are. So the Hawthorne effect, if you do something to somebody, if you pay attention to patients, they often get better. So is it the submaximal exercise, or is it the ritual of having the patient come in and having a blood pressure cuff put on them and going on a treadmill and being carefully monitored and giving permission to exercise up to a certain point? Is it the attention that makes them better because their fitness parameters don't change? This is the same thing with low back pain. Patients are given lumbar spine stabilization exercises, and they get better long before their core gets stronger. So it may be that we're paying attention to the patient. Patients often don't do well if they've lost locus of control, and you see this all the time. They will off-put responsibility because they don't feel as though they have power. So, you know, you make me better, fix me, cure me, save me. And once again, if you give them some sense of control, saying, you know what, we're going to have you do these cervical spine stabilization exercises and tracking exercises, and it will help you better, and you can control that. Oftentimes that is helpful for them. And so that may be yet another way that we can help them gain, if you will, locus of control so that they have the chance to not suffer so much. A lot of my work has been in the area of pain. And in that area of pain, we know that patients begin to believe that hurt means harm, and they will therefore avoid activity. This certainly may be true in brain injury as well, and maybe the submaximal exercise or the vestibular therapy, or even some of the exercises that we do in cognitive behavioral therapy, is to make the patient desensitized to their persisting symptoms after concussion. I will say it again, don't discount the brain injury, but understand that the reason that people get better is complicated. There is quite a bit of supporting literature now, both in terms of design of thoughts, but also actually studies that talk about catastrophizing and concussion, just like we talked about catastrophizing and chronic pain. Fear avoidance model, does that explain persisting symptoms after MTBI? And the term cognophobia, fear of thinking as though it will make your brain injury worse. So there's work in this space, there's more work being done in this space, and I think that we're going to see, just like with pain, the complexity of trying to suss out symptoms in athletes with persisting symptoms after concussion that seem well out of proportion to the severity of the injury. But then we need to look at our own beliefs as well too. So I've been certainly a victim of this, and I think we all are, is our own reasoning. So we like to interpret evidence to be consistent with our point of view. So if we believe, in my case, for example, that the mental health piece is important, and we do cognitive behavioral therapy, and the athlete gets better, then I say, well, you know, there's a strong psychological component. But if they get better with exercise, and you like submaximal exercise, you say there's a strong cardiovascular component. And if they get better with vestibular therapy or oculomotor therapy, you say, well, it's the eyes are the windows of the soul, and they're always involved. And if we do this oculomotor therapy, they get better. They do get better. But I think one thing I will encourage you to do during your fellowship is see as much concussion as you can, and try to see concussion outside just the athletic population. Because really, motivated reasoning sometimes is due to lack of pattern recognition. You have to see volume, because you need to understand what a brain injury is, and more importantly, what it is not. It is not a patient recently who came to me, 12 years old, and his mother said, ever since this concussion, he's been hearing voices. That is not a brain injury. That is schizophrenia, just like his uncle had. And these plethora of symptoms that last for months and months, you need to see, understand in your own experience. You need to recognize the pattern of how brain injury, mild traumatic brain injury, usually recovers. So the more you can see, if you can even, if there's a brain injury program in your fellowship and you're interested in doing sports concussion, spend some time with them if possible to understand the world of traumatic brain injury. So after a sports-related concussion, persistent, and I would like to say persisting symptoms, don't reflect a single entity. It's a constellation of non-specific post-traumatic symptoms that may be linked to coexisting or confounding factors, and they do not necessarily reflect ongoing physiologic injury to the brain. Therefore, a detailed multimodal clinical assessment is required to find out what's going on. What are the primary and secondary issues? And that, at a minimum, a comprehensive history. That's why you need to understand brain injury. A detailed physical exam, which is focused on the neurological system. And special tests, yes, do a graded exercise aerobic test and see if the patient responds. If you've seen one concussion, you've seen one concussion. The treatment always is individualized and is target specific, and that's based on your assessment and the patient making functional gains. So yes, introduce exercise if tolerated. Introduce targeted physical therapy if you think the patient has persisting cervical discomfort or vestibular dysfunction. And certainly look at a collaborative approach if you think that there are psychosocial or mental health issues. The key here, folks, is that this is a treatable problem. So it is our job for patients with persisting symptoms to offer hope. And I asked you earlier, what's different about concussion than it was 1,000 years ago? Is the remarkable disability now associated with it. So as a 20th and 21st century phenomenon, what often half the time was really never even treated has become increasingly disabling. Now, part of it, I hope, is we're better at recognizing those athletes who truly are disabled from brain injury. They may have a more serious brain injury. And also one reason that concussion can be disabling is it was never treated right to start with. There wasn't an adequate amount of rest, or there was too soon of introduction of more rigorous physical activity. So treat it right, and understand, though, that for those with persisting symptoms, we need to offer hope, and we need to be thorough in the way we evaluate these patients and figure out why it is they're suffering so much. It's the same thing as it is with low back pain. These are difficult cases, and no person as a standalone can manage them. I've been doing brain injury work for 4 decades. I don't treat these patients by myself. You always lose one-on-one. So for those patients whose disability tremendously supersedes their physical finding and mechanism of injury, find a team that can help address them, because it will take many people to help them limit their disability. So listen, once again, respect the brain injury. Make sure the brain injury has been treated correctly. Make sure the diagnostic workup is being done, and make sure that the reason they're not getting better is they have a more severe brain injury than you think they do. However, if we overlook or misinterpret pre-existing, coexisting, or persisting medical, musculoskeletal, and psychological symptoms, we make the treatment expensive, we make it unnecessary, we unnecessarily restrict students from academic, sporting, and social activities, and it also skews the research data. And remember, physical inactivity is truly a crisis. We want kids to be active and safe, but by having them stop all activity and never returning to sporting activity, we have to be careful about the message that sends and the consequences of that activity. Some of you may know that the team physician consensus statement is written every year. We've done it for over 20 years. The one that we'll have published next is on concussion, and this is some data from that. It's not yet published, but hopefully about late this fall. And what we said, you notice the title, Persisting Symptoms. And we said that the majority of athletes with sports-related concussion recover within a typical time frame, up to a month for kids. Persisting symptoms is defined as symptoms that last longer, and the pathophysiology is not yet entirely understood, but it's thought that it's not caused by a single event, but rather an interaction of post-injury symptoms that are complicated by pre-existing, coexisting, and resulting biopsychosocial factors. And be thorough about your evaluation and identify your treatment and make it specific for each athlete. That is my teaching point today, is look harder at the ones that don't get better. A view of the beautiful Pacific Northwest, but not lately because of the smoke and haze, but we hope that that clears soon. It is my privilege to give this lecture as a founder of AMSSM, and the joy of watching that organization grow to what it is today. If I can be any part in helping with your education moving forward, I am grateful for that opportunity, and I will stop. And if there are questions or comments, I am happy to take them.
Stan, thank you very much. That was amazing. I think we'll all have benefited from some pearls of wisdom there, and that may well have been a prelude not just to the team physician statement this fall, but to Paris in 2021 and the some of the topics that may be discussed. I have a couple of questions here. First question really to do with high school athletes, and why you think that high school athletes may have a prolonged recovery or be more at risk of a prolonged recovery more than any other population?
That's a great question, Hamish. I'm interested in your thoughts on it as well, too. There's been a lot of discussion about that as brains develop, they don't have as much adaptive circuitry. They haven't learned alternative pathways. And there's a lot of discussion about, at least in kids, about the relationship of the head to the body. So young kids, maybe it could be a cervical spine strength issue. I wonder, and once again, my bias is the psychosocial piece. This is a tumultuous time in a person's life. There's a reason that we still go back to our high school reunions 50 years later, because it was such a critical aspect of our life. I can't claim I understand the physiology of it. It's certainly a strong observational study. But I think that my bias is that it's because of who they are in their life and everything else they're going through, and they haven't really yet navigated all the adaptive skills. And they, part of it, I think, also is now the attention paid to this and the fear around it, Hamish. I mean, it's been my experience that they really are the at-risk group, and you have to intervene early to stop belief systems.
Yeah, I mean, I certainly see a lot of fear in parents and kids. I see a lot of student athletes at that age. I guess another question is sleep, and how much sleep may influence
Yes.
concussion. I think we've only begun to explore, how that influences athletes in general, but particularly after a concussion, that can be so problematic if people are not sleeping well.
I think thank you for that teaching point. And and in sleep, and you have to ask about sleep. It almost always is affected one way or the other. And to Dr. Kerr's point, that first visit, we call it the unlearning visit. So I ask my residents until they go in the room, and I say, don't talk. Ask the patient and their family what they believe is going on with the brain injury. Find out what they think is going on, because you often need to correct a material. We published a study that almost 70% of parents think that the incidence of concussion in high school football is between 10 to 50% a year. And 70% of parents thought that you could have chronic neurologic disease after one mild traumatic brain injury. So it's really important that you understand what they think and then use that to help sort out, are the symptoms being driven by anxiety and fear about the expectations for outcome?
Another question about different interventions for those patients with prolonged symptoms. Obviously, you've alluded to the fact that you have to individualize this, and there's not one treatment for all. But John Leddy's work in particular seems to have shown us that exercise is actually safe and can be initiated within a week of concussion, and that does seem to be, even if you're doing nothing else, if you're able to return people to exercise, that may be a really important step.
Right. Yeah, John should get a medal, because he started his work when it was in the cocoon phase. You had to rest the brain in a completely dark room, which is a rehab doctor I never understood, because if you can't do 4 hours of exercise with a moderate to severe brain injury, we can't put you on a rehab unit. So, he was courageous. I mean, he first had to show safety. And I think he's changed the landscape here. And yes, early introduction of exercise, once again, as tolerated. And my point being that exercise probably does a lot of things. I don't think that the level of exercise you introduce is there for fitness. I think it's there for movement and confidence building. I mean, you take an active athlete and you tell them they can't do anything, but versus letting them move a bit. So I think that, and I think Hamish, it'll come in Paris, that exercise is going to be validated as something to be introduced at a sub-maximal level early for most cases. Now, once again, if you have vestibular symptoms or other issues, you may have to address those first. But yeah, that his work is important. It's just fascinating to me that it's so helpful, even if it doesn't have a cardiovascular fitness effect initially. That's a very interesting piece of information. So yes, exercise early.
I personally, wonder how much sometimes the effects that we see from concussion are effects of just not being able to exercise versus recovery from the injury. I mean, that's almost impossible to tease out. But
that goes to your pattern recognition. I mean, the fact that you've done that's the key. You've done this so long, you say, you know what, this athlete, this isn't acting like a brain accident. This is acting like somebody who can't sleep at night and doesn't have much of an appetite because they're not exercising. Right. I mean, their cognitive function is improving. I mean, but they have their symptom checklist is full of things. But what does it do to? And that's exactly right. Even without exactly being able to suss it out, particularly when it's okay to move someone forward because it's not acting like a brain injury. And that's the critical piece that experience brings.
Another question that I often get asked by patients, patients are often reluctant to want to take medications for helping recovery, but supplements and specific components of their diet may have an influence even if they're not willing to consider medication. So is there any specific diet you recommend after a concussion?
Right, I get that quite a bit, and I'm interested, Hamish, to see what you say as well too. Sticking to the sports dietitians I work with, well, for everything, not just for this, I would really encourage your patients not to supplement. I mean, the fish oil piece I don't think is proven for brain recovery, and balanced diet, yes. Adequate nutrition, yes. Adequate hydration, yes. We are not. I rarely prescribe medication. Even acetaminophen or anti-inflammatories, I just don't find them effective. We certainly prescribe medications for mental health issues and those with persisting symptoms at times. Balanced diet, please stay away from any claim that a supplement's going to get you better faster. Listen to your provider. I mean, it is an opportunity to make sure they have adequate vitamin D, certainly in this part of the country, and iron and other elements, particularly for female athletes. So it's an opportunity to do some teaching there. We promote balanced diet, good hydration, but nothing else. Hamish, how about you?
Yeah, I think there's a real dearth of literature on effective treatment for post-traumatic headache and concussion. If you look at the pediatric literature for migraine headaches, there is some better data. And in that population where it's not necessarily associated with a concussion, there's some data to suggest things like magnesium, right, coenzyme Q, riboflavin may have some benefit. But again, that has not been well published in people that have had trauma. So I think early in my career I was more inclined to start medication, and the more people you see having problems and side effects from the medication, then you become more cautious. I mean, I use tricyclics and amitriptyline, nortriptyline more frequently in the past, but once you've seen a couple of people come in with a cholinergic crisis, then you get a little gun shy. So yeah, and again, what are you treating? Are you treating mental health issues, or are you treating concussion? So I don't know. I'm very much more along the lines of try and get them exercising, try and support their mental health. And vestibular rehab has, I think, Catherine Snyder's work was very important in pointing out how useful that can be.
I want you to listen to what Dr. Kerr is saying. If you have I see athletes very regularly who are symptomatic because they have post-concussion syndrome, and they have one symptom. They have headaches, and they've developed a post-traumatic headache disorder, but they've been held out of sports and kept home from school because their concussion symptoms are never going away. And that's why it's so critical to make the diagnosis. Those patients can be medicated. they have a medication treatable issue along with other issues, but that's why it's so important. This is attribution of causation. When a patient comes in to see you and they have symptoms and they've had a concussion, yes, they've had a concussion. They don't have a concussion anymore. They develop a headache disorder. So that's an opportunity to introduce medicine for a diagnosis where it'll help.
That's probably another evolving area of research. There's some data from adults that some of the new migraine medications may work for post-traumatic headache. There's basically weekly injections of an antibody that's been shown to be effective, but this is very early, and we're not really sure what what the level of evidence is on that yet.
More to come.
Yeah. One of the other areas that perhaps with medication we might consider treating is trying to help people sleep. Have you thoughts on use of melatonin in that circumstance? People having a difficult time sleeping.
It's the one thing I tell the residents is, if you're going to use medication for sleep, you should introduce it soon before the patient gets better. Sometimes if you wait, the sleep issues improve. But for those who don't, Hamish, I have read the melatonin literature. It seems mixed to me. I have found that the sleep disturbance often is a symptom of something else. Anxiety, fear, pain. And so putting a young athlete on anything beyond melatonin makes me anxious. As you said, then Hamish, do you let them play? I mean, if you put them on a tricyclic and they're sleeping, do you let them play then? It brings up a lot of questions. So if someone has a significant sleep disturbance that's persisting, it's rarely in isolation. So what do? Do we sometimes use medicine? Yes, but that's after they've detoured through submaximal exercise, that I've cleared their cervical spine, that I've got them doing balance and activities, and also that they've had an assessment by the mental health partners in our clinic. Then, so the question is, the lack of sleep the victim or the culprit?
Yeah, I would agree with that. And I think it's an opportunity really just to go back to sleep hygiene and make sure that they're doing all the simple things before you jump to medication, as we would in family medicine clinic for other patients without a concussion. You got to do your due diligence to make sure that they're closing their curtains, turning off the lights, and watching TV and stuff.
Right. And Hamish, to echo what you said, if most of the physicians on this phone call had been trained in family medicine or internal medicine or physiatry for that matter, do what you always do. Right? Do what you always do. Do a thorough history. The mystery's in the history. And so you don't accept that every chest pain is cardiac. Or every abdominal pain is hepatic. It's the same thing here. If someone has lingering symptoms you cannot easily understand, you have to look. Agreed.
I would also just echo something that you mentioned in the middle of your talk, Dr. Herring. Just as a fellow getting experiences in concussion and seeing a volume of patients with concussion is so important. In my fellowship, I was lucky to be able to join a multidisciplinary clinic, including physiatry, including neurology, including neurosurgery and sports medicine. And, there was different variations in management styles and treatment for each. And I found that invaluable. So not everyone has those opportunities, but certainly I agree with Dr. Herring's suggestion. Get experience of managing brain injury during your fellowship, and if that's a concussion clinic or if that's a specialist multidisciplinary clinic, it is really important, because otherwise you'll just see the simple, straightforward concussions that get better within a couple of weeks and you don't have to do much. And that is not the reality in the real world.
Thank you. I mean, And listen, the parallels, if you have experience in a pain center, there's a lot of parallels here, but it's the multidisciplinary piece, and it's learning pattern recognition. And particularly if you're going to cascade this forward in your practice and state that you treat concussion, you need to build a network before you start doing that. Like I say, I don't treat these patients by myself, and it just doesn't work. And we want to be very, very careful to not disable a young group of people with treatable disease. And we want to be always respect the brain injury, but yeah, I think it's on us now to try to do something about the rising tide of disability associated with this injury.
Well, we're winding down to the last minute or two before the hour is up. I just want to take a last minute just to thank Stan for providing his wisdom. This has been a really useful and very, very clinically relevant discussion today. I hope you've all benefited from that. It's obviously going to be available for review on YouTube later. Please do pay attention to Andy Meyer's request for you to fill out the survey after tuning in. That's important for us to understand. You know, honestly, there could be 10 different lectures on concussion. There's so much to talk about. So please fill out the survey. And Stan, thank you. And we hope to see you in person again at AMSSM in the future.
Yeah, thank you. Listen, really an honor. You know, what a great way to start my day. For once, I'm in my study talking to myself, and it means something. And so as we all navigate the new reality, I hope your training will be different, but I'm sure you'll all thrive and support AMSSM and build your practices. But listen, thank you, Hamish. Really an honor, and good luck to all of you.
Thanks very much, Dr. Herring. Very much appreciated.
Take care.
Okay.